Running the back office of a modern neurosurgery practice is an exercise in extreme administrative friction. According to Kodiak Solutions' 2025 revenue cycle data, U.S. hospitals and health systems missed $48.4 billion in net revenue. Looking at this chart comparing 2024 to 2025, we see a 25% increase in revenue leakage, driven largely by an average initial denial rate climbing to 11.6%. But for specialty neurosurgery practices, that 11.6% is a baseline, not a ceiling. These procedures involving the brain, spine, or nervous system carry the most denial-prone characteristics in all of medicine. Yet mid-size practices routinely attempt to manage this layered complexity using the same generalized revenue cycle protocols they apply to standard office visits. General billing staff are stretched thin across a dozen generic administrative tasks and lack the specialty-credentialed expertise required to navigate these particular claims. Treating neurosurgery billing as a generalized administrative function mathematically guarantees systemic, large-scale financial loss. To understand why these claims fail, we have to look upstream at the prior authorization process. This diagram illustrates the sheer volume of the burden. The latest American Medical Association survey shows physicians and staff now spend an average of 13 hours per week managing prior authorization requests. That time goes toward completing an average of 40 requests per physician every single week. And despite that heavy investment of staff hours, nearly 32% of these meticulously prepared requests are often or always denied. In neurosurgery, you cannot bypass this step. Almost every major procedure, from spinal fusions to craniotomies, requires advance approval against varied and shifting payer criteria. This intense workload creates a compounding operational variable, severe turnover in medical billing staff. According to MGMA data, annual turnover for billing staff in practices with fewer than 25 providers now exceeds 38%. Replacing a single frontline biller costs between $25,000 and $30,000 in recruitment, onboarding, and lost productivity. When you factor in salary, benefits, software licensing, and turnover, the true fully loaded cost of an in-house biller totals $90,000 to $140,000 annually. Mid-size practices are burning massive capital on a fragile staffing model that bleeds institutional memory and actively drives down revenue. The structural failures extend deep into the mechanics of the claims themselves, particularly within the 90-day global period. This timeline represents a standard 90-day post-operative billing arc for major neurosurgical procedures. A flag drops at day 45 for a routine evaluation and management visit. Because it occurs within the active global window, payers automatically deny the claim. Securing payment requires a pending Modifier 24. Modifier 24 explicitly communicates to the payer that the specific visit is entirely unrelated to the original surgical procedure. Tracking overlapping 90-day global periods across a busy, multi-surgeon schedule requires exact precision, making it structurally impossible for an understaffed office to manage manually. Other codes, like Modifier 78 for a return to the operating room or Modifier 79 for an unrelated procedure, have similarly strict rules that demand case-level surgical review rather than bulk processing. Modifier management is a strict specialist dependency. A single missed detail by a generalist biller causes immediate, localized revenue leakage on high-value claims. The exactness required by payers is escalating. In 2025, CMS and commercial networks mandated highly granular ICD-10 codes for neurosurgery. Here is how that structure works in practice. If a biller pairs CPT 63030 for a lumbar laminotomy with diagnosis code G96.9, an unspecified CNS disorder, the claim instantly hits a rigid payer audit flag. Pairing a highly specific surgical code with a generalized diagnosis code immediately fails the payer's medical necessity check. To clear the audit, the diagnosis code must physically map to the exact surgical necessity language documented in the operative notes. A newly hired generalist biller rarely knows how to spot these specific clinical nuances. Mastering the full landscape of neurospecific CPT codes, global period rules, and ICD-10 specificity requirements takes months of active training. During that long ramp-up period, coding errors accumulate, rejections stack up, and severe billing backlogs rebuild. If there are upstream documentation failures in the operative report, like missing modifier justifications or broad medical necessity language, the revenue cycle team is forced into massive downstream rework. Specialized neurosurgery coding is a data-exact discipline. It breaks down completely when subjected to high staff turnover and generic batch processing workflows. To stop the financial bleed, high-performing neurosurgery practices are shifting away from the in-house billing model entirely. Instead, they partner with AAPC and AHIMA credentialed neurosurgery billing specialists who work directly inside the practice's existing EMR. This financial comparison model illustrates the structural shift. Practices are trading heavy, volatile variable costs of up to $140,000 for a highly predictable fixed cost model. The resulting arbitrage is clear. Staffingly provides dedicated neurosurgery RCM experts at a fixed rate of $399 per week per seat. At roughly $20,748 a year, practices realize direct savings of more than $44,000 annually per position, compared to mid-range in-house staffing costs, entirely eliminating turnover risk and benefit loads. This specialized human expertise is actively augmented by AI tools built into the workflow. Smart routing correctly assigns claims, while automated pre-submission audits analyze the data to catch granular coding errors before the claim ever reaches the payer. Combining dedicated, credentialed coders with pre-submission automation drives error rates strictly below 1%. The operational transition is fast. A practice reaches go-live within a 14-day window, fully supported by SOC 2, HIPAA, and HITRUST compliance infrastructure. Scaling a neurosurgery practice requires restructuring your back office around specialized precision rather than constantly trying to outstaff a broken system. Visit staffingly.com/demo to secure a 14-day risk-free pilot.